Dr. Anna Laura Arteaga-Biggs is a psychologist out in California, and I interviewed her on episode 6 of this podcast, where we talked a bit about just finding empowerment in your medical care and in your social circles, especially as you're going through really difficult times. And last time that Dr. Anna was on the podcast, she was going through some health issues. There was a lot of confusion around what she was going through, and I know that a lot of us experienced that same situation. So Dr. Anna came back and we recorded an episode, honestly, a few months ago at this point, but it's been a while since I've been able to edit and stay consistent with uploading podcasts. So I am uploading her episode today, and yesterday we actually recapped again, because in this whole episode you'll hear that she's talking to me pre-surgery. And then she gave a kind of 15-20 minute update post-surgery. So I'm excited for this episode because we haven't really done something like this before. We talk a lot about kind of stories, personal stories, and you get to hear from therapists of all different kinds and what they've been through. But this one is really in real time. So Dr. Anna has been incredibly gracious in sharing her real-time story with us, and I hope that you all get a lot out of it. Also, I wanted to be really clear here, we both wanted to be clear, that while we are using the term women, we really are talking about anybody who identifies in any minority group. Historically, history will talk about men, women, but just keep in mind that anyone who is gay, lesbian, transgender, anything other than cis, hetero, white, basically was lumped into, in the history, they were just completely left out, or lumped into this group called women. So we use the term women here, but this really is inclusive to anyone who has any identity frame.
The Chronic Illness Therapist podcast is meant to be a place where people with chronic illnesses can come to feel heard, seen, and safe while listening to mental health therapists and other medical professionals talk about the realities of treating difficult conditions. This might be a new concept for you, one in which you never have to worry about someone inferring that it's all in your head. We dive deep into the human side of treating complex medical conditions and help you find professionals that leave you feeling hopeful for the future. I hope you love what you learn here, and please consider leaving a review or sharing this podcast with someone you love. This podcast is meant for educational purposes only. For specific questions related to your unique circumstances, please contact a licensed medical professional in your state of residence.
I am really glad to see you here. I'm curious, what prompted you to want to talk today? Like, was there something specific on your mind that you wanted to go into?
Yeah. So since we last spoke, which I re-listened to that, I think that was January 5th of 2021. Does that sound, or was it 2022?
2022. Yes.
2022. So much has happened since then. And I was recognizing that when I was listening back to our first podcast, I had really minimized unknowingly, I think, and really invalidated what was going on for me medically and with my own things that I was sort of navigating. And I think a lot of that has to do with just being gaslighted by multiple medical professionals. And I've since come to learn a lot more about what I've been living with and dealing with for so many years of my life. And I'm becoming even more passionate about it. And I want to provide good information so that people can get quality care.
I remember also last time we talked, you were experiencing I think a lot of grief, a lot of death in your family.
Mm-hmm.
And
Yes.
I would imagine all of this is connected, right? Because nothing lives in isolation.
Sure. I mean, I haven't necessarily recently connected all that because I think when we were speaking, it was just still, the height of COVID. And I also, at that moment in time too, I was pretty deeply in experiencing postpartum depression with my second child. And I think there was just so much happening, and I was probably a little bit removed from what I was experiencing emotionally. I was really just trying to survive, which I think I've probably been trying to do for a really long time. And I think I've gotten good at that and didn't really recognize that within myself. I can see it and identify it so easily in the work that I do with my patients, and particularly within the population of chronically medically ill women. I think that they're very good. We are very good at presenting like we're doing a lot better than we are. And so, yeah, I think there's just so many updates to what's happening with me. And I felt like it warranted a conversation around women's health and the way that it's navigated, and with particular focus today on endometriosis and adenomyosis. But I think more so the endometriosis part of things, just because there's much more that can be done there than there is for adenomyosis, which is also obviously a women's health issue that needs to be discussed as well. But there's a lot to happen for me in the next 10 days. And so I just really wanted to connect with you and connect with women that might be going through similar things or looking for answers. And I wanted to be one place that they can find evidence-based information, and maybe just process some of the grief and the rage that accompanies these really frustrating diagnoses. So
I'm so glad you brought up rage, and I think we definitely need to talk about that later on in this episode. But first, can you talk a little bit about, endo and adeno, and how maybe some of your gaslighting experience and how you ended up getting the diagnosis and that part of your journey?
Yes. So I feel like whenever you have probably, I think anything in women's health, but any of these sort of, pelvic related diseases that you could probably spend 8 hours talking about all of the care or just your symptoms and when you first noticed. And I think for me, it's been a lot of going back and realizing that things that I didn't realize were connected were absolutely connected. So what I'll say is that when I first, got my period at 13, I mean, I think a lot of the signs and symptoms were there, but I just didn't know what I didn't know. And I wasn't, I mean, I really love my family, but I did grow up in a house where I think, up until recently, like vagina was a bad word, or, it's something that my family didn't, I mean, they still kind of cringe when I forcefully make them say it, and vulva and these kinds of things. I mean, I didn't even know that word, I think, until later into adulthood. And that's just insane to me. But it just wasn't, I don't think that it felt really comfortable for me to talk about these things and ask these questions. Not that my family isn't really safe and loving and supportive, but maybe around these kinds of things, it just wasn't really the culture of my home. And so my periods were,
yeah, I just wanted to add in there, when things are unknown, they're unsafe. And so it sounds like, yeah, you've got a supportive family, they loved you, but if we don't even have the language to talk about our body parts, then the whole thing feels unsafe, and we just try to kind of stay at an arm's distance from it.
Sure. Yeah. And if you don't, I mean, if it's not really being discussed, you don't know what is normal or healthy, and at school, I mean, I don't even have to go into the specifics to indicate that the education around these things at school, especially back then, I mean, I'm sure even now, but when I was 13, it was just not what it needed to be. And sadly, I imagine that's probably still the case, and especially depending on what state you live in. I am in California, which is probably one of the more progressive states in that department, but even still, I imagine we're just not where we need to be. So yeah, my periods were quite intense. They would last about 2 weeks long. The bleeding was really, really excessive. And I didn't know that my cramps were really painful, and it just felt like, oh, this is just how it goes. This is part of it. And around age 14 or so, I started experiencing pain in my left side, which I now understand was my ovary. And I was feeling myself ovulate, which I've since learned is actually not normal. It's really abnormal to be able to feel yourself ovulate, but I can tell you the second it starts happening, I can tell you when I'm ovulating. It's like that intense. I'm that aware of my body, and I was feeling all this pain. And so
just because I take a somatic approach, my curiosity is around some of the sensations there. I'm curious so people can kind of get an understanding for themselves too. What kind of sensations did you feel that you now know weren't normal?
just a sharp pain right near where my ovary is, which I think when I was 13, 14, I didn't really even know what an ovary was or exactly where it even was in my body, or that, I wasn't supposed to feel that. And when I went to the doctor, she just said, oh, she's just probably ovulating. She's fine. And that kind of that was my first experience with a gynecologist. I remember being very anxious. I'm not comfortable with nudity in general. And that really comes from the modest sort of culture I was raised in with my family. And so I think all of that it was scary for me to explore those things. And it made me really uncomfortable with doctors and those kinds of appointments. And I think that also led to a pattern of avoidance where if I needed to navigate something that was happening in my body, I would avoid it at all costs because I was pretty fearful of procedures and doctors and pain. And it was accompanied with a lot of anxiety, which I think would exacerbate the treatment that I would receive, because then it was so easy for them to go to, she's just a really anxious person, and all of this is just anxiety, which is, there's a lot of historical implications for that for women around hysteria and that we aren't taken seriously and our pain isn't taken seriously, especially if we're women of color, and particularly Black women. Do not, they're just not taken seriously. And that leads to a lot of really dangerous complications, including death, which is just terrible. So essentially my story kind of continues where this was kind of my life for most of, my adolescence, young adulthood. And it really wasn't until I became a postdoctoral fellow at a hospital in Los Angeles, which was really eye-opening for me. And it made me very aware of what was happening in my own body. And I was exposed to diagnoses that I had never really heard before. Maybe I had heard, but I just hadn't really registered that it was applicable to me. And so as the psychological consultant in behavioral medicine in this particular hospital, which is a hospital that, it's poverty medicine. So these are the population that served there was predominantly monolingual, undocumented Spanish speakers. And I'm a native Spanish speaker. I'm from Argentina originally. I'm an immigrant. So I speak Spanish, so I was able to provide those services in their native language. And what I saw horrified me. These women were in so much pain. And essentially what they were being told is really, there's nothing else we can do for you. And there was an annoyance, which I now also really understand as, I think, an exasperation on the medical side, because these doctors, when they learn about endometriosis, their medical textbooks have one sentence about endometriosis, and it's not even accurate. And so they're not even learning about these things, which impact 1 out of 10 women that we know of so far. I'm sure there are more. I shouldn't say that with such certainty, but I would imagine there are more cases than what we know about worldwide. It has been largely sort of seen as a white woman's diagnosis. And that's because that's who's getting care for it. And that's who's making noise. And when white women make noise about things, then people tend to listen a little bit better. But, you know, I was watching women in so much pain, so exasperated, basically begging me for help. And they were being accused of drug seeking by a lot of these doctors. Or the doctors, if they weren't accusing them of that and they were trying to be empathic and helpful, they just didn't know what else to do for them. And the problem was is these women weren't receiving what they needed, which was excision of their endometriosis. They were either probably getting ablation or being put on things like Lupron, which just creates an even bigger problem. And creates many new and worse problems. So that was sort of my intro to this world, and I got to see things behind the scenes. And it was the first time that I realized I don't trust the medical community the way that I grew up thinking that I should. The other piece of this that complicated things for me is that when I was a fellow, I was required to wear a white lab coat when I was in the hospital. And the way that people treated me with so much respect when I was wearing this stupid coat, when I didn't deserve it. I was just a young fellow. I mean, I was smart and I knew some things, but I really didn't know much or a lot, and definitely didn't warrant the level of respect that people gave me. And that was really powerful for me because it showed me, you know, now I'm being called doctor for the first time and I'm wearing this coat, and it makes people feel like I know what I'm talking about, or I should, or that I have some sort of authority and that I should be listened to without being questioned. And particularly from cultures where being submissive or, you know, being respecting people in positions of power, particularly, you know, in this country, it was really shocking to me, and it has stayed with me and has allowed me to be mindful of when I might be sort of bewitched by somebody with a fancy letters on the, you know, behind their name, or wearing these tools or these, you know, coats, and it makes you feel like you're in the company of someone that really is an expert, and perhaps they're not. And I've now since learned that most gynecologists don't know, they're not only not experts, but they really know less than many of their patients do about what's happening inside their bodies. And that is, I don't know what word. I think rage inducing is that the right word? Probably there's a lot of different words you could use to describe what that makes me feel, but
why do you think this is? Why do we know, other than the fact that we're living a lot of the, you know, we're living with these experiences, but
I think it's a systemic issue. I mean, I think that the system is set up for research to predominantly focus on men and men's health. And that's why there's so many solutions for so many men's ailments. And then those things are being used on women, and it doesn't work for us because we have different hormones. We have different, you know, things in our bodies. And I'm clearly not a medical doctor, so I won't, you know, I won't dive into something that I also don't know anything about. But something that has, you know, that stayed with me is, as a psychologist, I know a lot of things about certain areas of psychology. And then there's a lot of areas about psychology that you should definitely not come see me for, because I don't know what I'm doing. And if somebody does come to me or calls me and says, I'd love to work with you, here's the problem that I'm having, and I know that I don't know enough about that, or I know someone who knows a lot more and would be a better fit, then ethically, it is my job to say, I would love to work with you, but I think there's a better fit for you. Or, you know what? That's outside of the scope of my practice. I'm not an expert in that, but hey, there's somebody just, you know, down the street here who's a colleague of mine, and they're fantastic and they know a lot about that thing or these issues, right? And so I think that
too, it's like not even just about spending your time learning more textbook knowledge, but also just making connections, you know, networking in a way that's like a human connections, right?
Well, and advocacy, and I mean, there's so much that needs to be done. I mean, it's exhausting to really think about, and I certainly am not purporting to have the answers to this, that I know what needs to be done. I just know this isn't working, and doctors are failing us, the system's failing us, insurance fails us. There's so many intersections here between, racism, sexism, misogyny, just socioeconomic status. I mean, when I think about my case is really not unique. It's not special. My case isn't interesting or different than the rest of the cases in this. If anything, it's probably less dramatic and intense than so many others. And I have privilege and access to, so many resources and, money as needed. And my level of education is really high. And even with that, I still got screwed by a system. And so it makes me think, wow, if I come into these appointments with all of this knowledge, with all of this access to, colleagues who are medical doctors, training in all these areas, I can advocate for myself. I'm also not shy about using my voice. I'm not shy about being confrontational. And still, this happened to me. And I know we haven't even sort of completed kind of my story in terms of my journey of my diagnosis, but it's alarming to me. And I feel like it has lit a fire in me to hold a megaphone as often as I can. And that's also part of why I really wanted to do this podcast today and just check back in with you, because I feel like these conversations need to be accessible to as many people as possible.
Yeah, I agree. I'm really glad you're feeling up for talking about it and that you are here talking about it. And I'm curious, what is kind of the next part of your journey and maybe some of the things that went right and went wrong to get there?
Yeah, essentially at that time, I became really attuned to what was happening. I remember speaking to my supervisor. My supervisor was a very unhealthy person emotionally. It was actually fairly abusive to me and to other fellows. Sort of historically, I kind of learned that later. But she actually was kind of the start of that minimization, where she sort of said, "Oh, it's really common as a fellow here to start thinking that you have things in your body that are going wrong, and it's really just kind of in your head." So that was the first time that sort of put it in my mind of like, oh, maybe I am just sort of a little bit of a hypochondriac, which in fairness has been sort of the running narrative about me since I was a small child. I think I was sort of set up for people to not believe that I was really in a lot of pain, or my pain was seen as being experienced in a way that was excessive and probably not what's the word, compatible with what was happening. And so I think I also learned to deny a bit of my own pain and see myself as just fearful. And I think that it was a little bit of both and, right? That I was fearful and I did have more anxiety about medical things. And we sort of talked about that in the first podcast, that I hadn't seen myself as someone that could even really listen to hearing about other people's pain, because I would feel it so intensely from kind of like an empath sort of way of feeling things, the way people feel them.
Really want to, I think this is so important because so I grew up with my mom. Everyone called her hypochondriac my whole life, and I have had a lot of anger towards my mom for being this way. So when I started to feel pain in my own body, I was like, oh no, like this is in my head, like I'm turning out to be just like her, like. And now I realize that those of us who are called hypochondriac have an extra sensitivity to pain because there is something genuinely happening inside of our body. It doesn't necessarily mean like, you absolutely have some kind of chronic illness, but we have just a heightened sensitivity to pain. And then when you have a society that's like, no, that wasn't true, that's not what's happening, or, no, this isn't true, and they just minimize your experience, our fear centers in our brains say, no one's listening, so we have to shoot even higher. And so it's just, when I work with parents, I'm always trying to really bring home the point that validating their pain is always going to be the best solution. It doesn't matter if you think it's real. It doesn't matter what you think about it at all. If you deny it, you actually will make it worse.
Absolutely. Well, and pain in our bodies it's a signal that something's wrong. So when your body's in pain, it's telling you, hey, something isn't right here. And I think pain is one of those things that it really is felt differently by different people. And it also changes as you experience different levels of pain, right? And so after having, going through childbirth 2 times, I had really long labors. They were like 30 plus hours, and I pushed for 4 hours with both babies. So I now think I have a different pain tolerance than I did, a few years ago, or a different experience of what my body can handle. And so, yeah, pain, it's all relative, right? I mean, I remember my brother-in-law got in a car crash, or I'm sorry, he was hit by a car. And when he got to the hospital, they asked him what his pain was, and he said a 4. And I remember he was really celebrated for that, of like, wow, what high pain tolerance. And I remember really rejecting that and saying, why are we celebrating that? Because was he possibly minimizing his pain because of, toxic masculinity? or does he just have a different tolerance of pain? And should it be celebrated, or should it just be sort of this neutral, like, oh, okay, you're a 4, and for you that means this, and if you were at a 7, that would mean that somebody was cutting off your head or something. I don't know. I mean, it's such a strange system to rate pain that way. I always tell doctors I'm at an 11. They're like, 1 out of 10. I always just add a number to the chart. I'm like, it's an 11. Just, it's really high.
Yeah. I the last
manage.
episode that just aired before this last Friday was called The Pain Scales Bullshit. And I had Nadia Klontz on, and we just talked about that the whole time. And I did a talk at a community, it was a community mental health agency, but they have an interdisciplinary team in a hospital and very much lower socioeconomic status. And when I brought up that the pain scale like shouldn't even be used, I got so much pushback by the doctors in the room. Like they were not happy with me, and that's okay. I'm okay with that. But yeah, it's just really, it's like, well, we have to use it for to see like the start and the end, like progression of treatment. And I'm like, I didn't argue too much because I was a speaker, and I just felt, and it was through Zoom, and I couldn't even see their faces, so it was just like a weird kind of talk. But my comeback to that is like, how pain is up and down. There is no like, at the start of treatment, I'm a level 11, and now I'm a level 2. So all good to go. Like, it just doesn't work that way.
Correct. And sometimes it's hard. It is a complicated, and it is a problematic system. I think there's probably better ways of doing that. But I'm trying to remember where we were at as far as, I think I was just sort of telling you about my pain kind of being minimized, or people sort of thinking, oh, she's a little bit of a hypochondriac. So I think they didn't think things were as serious with me because they felt like I tended to exaggerate anyways, and then things would just be fine. And so I started, at this point, I was about 20. Let's see, how old was I? Like 29, 30, I want to say, right in that ballpark. And I started being more proactive, and I went to a gynecologist up in Long Beach, and that was recommended. And I started telling them, I have all this pain, and, I can't do this, and I can't do normal things, like sex is extremely painful for me, to the point of just, I have so much avoidance about it, because it's just, why would you want to do something that hurts so much when it's not really supposed to hurt? And so I would just be told, you just need to relax. You need to just maybe have a glass of wine. Like, alcohol was really pushed, I feel like, in these settings of like, just drink a little and you'll be, more tolerant to things. And you're probably just in pain because you're resisting it. I know. And so I just thought, okay, what the heck? Something's wrong with me, like something's wrong with me, maybe just from a psychological standpoint, because they're looking at me and they're telling me everything's fine. And that kind of persisted. And then I got married, and I was trying to have a baby, and I couldn't get pregnant. And it didn't really fit with the narrative of the rest of my family's sort of pregnancy stories. It seemed like, my grandmother had 5 children. My mom had the 2 of us pretty easily. Granted, she was a lot younger than I was when I started trying, but still, it just felt like, my sister, everybody was able to get pregnant fairly easily. And I wasn't getting pregnant, and I was worried. And so I went to a doctor here in San Diego. I had moved back to San Diego at this point. And this was the first doctor that listened to me. So I don't want to celebrate her too much because the story after that does not take a good turn. But I will say, getting the diagnosis was such a freeing, liberating feeling. And I remember just feeling so much relief. And I hear that all the time. I do hear that with the women that I work with. It's just a lot of them spend 8 to 10 years just searching for a diagnosis, and they're told it's just anxiety, it's just psychological for all these years. And then they finally get that diagnosis, and it's such a relief, even though it should be terrifying in a lot of ways too, because now you're learning that something is seriously wrong. And yet it's crazy to me how much relief comes from the knowing. And so that happened for me. She did a laparoscopy. She found endometriosis, which I had suspected. So it felt nice to know, hey, I'm not, crazy, and I know my body, and I was right. So at that point, she also told me, your uterus looks, quote, beautiful. Your fallopian tubes are clear, so you should be able to get pregnant. You just have a little bit of endo in this area. It's not that bad. I didn't touch it because if I touch it, it makes your infertility become, it can make you infertile. And so, okay. So I thought, okay, well, she listened to me. What a great doctor, so I believed her. So I went and continued trying to get pregnant, trying. Nothing was working. Spent a good 2 years in that boat. I finally went to a reproductive endocrinologist and continued there. I went through 4 IUIs, which is intrauterine inseminations. Those did not work. At that point, my RE, he suspected adenomyosis. He knew I had endo, but he didn't do much about that because my other doctor, who's in the same building as him, had already confirmed it and kind of said, it's fine, it's not a big deal. So he looked on a transvaginal ultrasound and found something suspicious, which was not common. Usually you don't really pick that up on a transvaginal ultrasound. So it was good on him. Another sort of good moment. I can sort of appreciate that he found this because I don't know that it would have been found otherwise. He sent me for an MRI, and it was confirmed, to the point that it can be, because with adenomyosis, really the only way you can fully confirm it is when you remove the uterus and biopsy it to confirm, right? And so, but essentially it's at this point, it's been triple sort of confirmed of, yes, you definitely have this. He noticed my uterus was a lot larger than it should be. It is also retroverted, which you'll hear that that's common, and that, it's kind of like an innie or an outie belly button, which I've since learned is not true. If you have a retroverted uterus, that's often a sign that something's wrong. Often it's an endometriosis related thing where it's being pulled back and tipped back, or it could be another thing like fibroids or something. And so that's, it's sort of a new development that I didn't know. And at that point, I just assumed, well, that's why I couldn't get pregnant. And that could very well have also been the problem. I went to IVF at that point, and I was very lucky that both times with both babies, it worked on the first transfer, and I was able to, get pregnant and carry both babies to term and have sort of, healthy babies. So that part ended well for me. And then after that, I started doing a ton of research. That's where I found Nancy's Nook on Facebook. I'm no longer on Facebook, but I started to learn a lot about endometriosis and found that everything that I'd been learning online was utter garbage. And then I started to realize, hey, this gynecologist that did this surgery didn't do it right. And thankfully she didn't touch it, because if she had, she would have used ablation, and that would not have helped me at all. So this is where the story gets a little complicated.
Sorry. Yeah, just real quick, do you know, and it's okay if you don't know, because again, you're not a doctor, but from your experience, what would have, was there something that she could have used that was an ablation that would have helped, or not touching it was what was?
So, the answer is a little complicated, because yes, there is, but it wouldn't be good for her to do it because she doesn't know what she's doing. So you only want to go to a doctor that actually knows how to do this surgery. And the last time I checked, and somebody can correct me, and if people write comments on these, I don't know. I welcome that feedback, because I just know what I know, and to the best of my ability, and I'm sure some of this is incorrect. So I welcome being told that. But last I checked, there's roughly 50 to 100 doctors worldwide that can actually do this surgery properly. It's called excision surgery. It's done usually robotically. And it takes a really special sort of trained eye to see the adhesions, because some of these adhesions are not obvious. They're different colors. Some are black, some are white, some are really, really subtle, that if you don't know this disease well enough, then you would completely miss it, which is what happened in my case. So what she should have done, if she knew what she was doing, was do excision surgery while she did the laparoscopy. So, and the way I just said that is confusing. Excision surgery is done laparoscopically. But my point was that often women that have this, you sort of get the diagnosis the day you get the excision surgery. So it's sort of weird, because you can somewhat, in certain cases, pick it up via a transvaginal ultrasound or other means, but you often can miss it that way, or you can't see the full picture. So the only way to really properly diagnose it, and sort of the gold standard, is to diagnose it via laparoscopy. And if you do that with a trained excision surgeon, they can both do that and then remove it in the same day, which is more beneficial, because then you're not going through multiple surgeries. Because essentially what she did is just inflame the endo. She went in there, she caused a ton of inflammation and pain, and then I was worse off afterwards, which I didn't know that. So what I've since come to learn is that, once I have an almost 2-year-old and an almost 4-year-old. And so my goal was, once I can kind of come up for air, I'm going to take care of my body and go, deal with this, which I knew was going to be excision surgery for the endo, and then a full hysterectomy for the adenomyosis. And I'm done having children.
That's actually really important, I think, to maybe pause on, like, that you made this decision to allow yourself to wait until maybe the timing was a little bit better. Because I think a part of like pain and fear and some of the mental health side of this stuff is like, we can get into such fight or flight. And I'm sure, I mean, you can talk more about your experience around that, but I think too, the ability to pause, even though I'm sure you still had a lot of fear during that, but to pause and to say, like, this is what's best for me in this moment. This other thing will be what's best for me in the next moment. And to kind of take it step by step is how we get through stuff like this. And that's what I preach on this podcast. And that's what I teach all my clients. And so I just wanted to kind of really illuminate that for a second.
Yeah. And it's tricky in my case, because now what I've learned is that I needed emergency care back in 2016 when I first got the first surgery. And so
so it's like, really, you didn't need to pause at all. You really needed it back then. But the fact is, you didn't have a doctor who knew or could educate you. You didn't know. And so then you had to.
She was completely wrong. Her whole, thing was that when you get pregnant, it'll cure it. You just need to get pregnant, which is a really common. It's like the 2 things you'll hear, or 3, is you need to relax, you need to drink a little, and just get pregnant. And, infertility is always the number 1 priority for doctors. They don't listen to them. And there's young women that want full hysterectomies for whatever they might, whether it's fibroids or other things that they have, adenomyosis. And they're not given that as an option, because people sort of think, oh, you'll change your mind, because they think that everyone just wants to have a baby. And the truth is, a lot of people don't, and that's okay. And people should be able to make decisions about their own bodies. And they're not. In my case, fertility was important for me. So clearly, like, I wasn't going to have a hysterectomy for the adenomyosis, because I was being told, yeah, you'll be able to safely carry a baby with this. And yeah, you'll want to remove it later. And then the flip side happens, where with endometriosis, doctors think, I'll just remove the uterus and all the things. And that's actually it's not what should be done. It actually does not remove the endo. And there are certain cases where that is an acceptable protocol to use, but that's actually quite rare with endo. With adenomyosis, it's the only option. With certain fibroids, it's also the only option currently, which also is not okay because we should have more options, but the research isn't being done to provide us with alternative, things that will cure us or help us or ease the pain or, be safe. And so it's like we're just removing all these organs, which has a lot of implications and leads to a lot of other complications and more things to have to deal with. But in the case of endo, if your doctor's saying, oh, we'll just remove all these organs, you should probably run unless you have a really specific case that is so egregious. Lena Dunham being one of those people. She's a writer, producer, actress, for those who haven't heard of her. And she's also kind of one of I read her book, and then that's when I sort of saw a lot of myself in her story. But her case was particularly intense and different than mine in so many ways. But anyhow, I'm going on a tangent, but I want to be specific about this because I've had friends who have had hysterectomies for endo, and it absolutely kills me because I know that they still have endo and now they had all these organs removed and they're dealing with hormone replacement therapy and all these things, which they didn't need to go through, especially at such a young age. So back to, I decide to get care. I prioritize myself again. That was kind of my big goal I turned 39 and now I'm 40. And I decided, this is what I'm going to do. So in doing my research, I found, there's only about 50, somewhere between 50 to 100 of these, what they're called sort of Nook surgeons. And that comes from Nancy's Nook on Facebook. So these are sort of approved surgeons that have shown they actually do a really good job. They have a good success rate or high success rate at removing the disease, where women either never need to go back for another surgery, or in some cases, maybe it grows back, but they, are living normal, happy lives again, pain-free lives. And so I found at the time that I looked, there were none in San Diego. There's one or two maybe in LA, and really only one that I would recommend up in San Francisco. There are two listed, but one of them I would not recommend, and I will not say their name because I don't want to be sued. But anyhow.
And where can you find these lists of the doctors worldwide?
It's on Nancy's Nook. It's a group on Facebook that you have to join. Okay. There are some problematic things about Nancy's Nook, so I can't give it my full, I fully 100% recommend it, but I will say that currently it is one of the few places where you can find evidence-based information and you can find doctors that actually really do have expertise in treating this disease and removing it surgically via excision surgery. So there are some other political things I think happening there that I guess that's to be expected in some ways. So there's certain things I'm being careful, as you can tell, and I think I sort of have to be, but so I'll just sort of keep it there. But I'd say take it with a grain of salt, but that is one area that I think you can find valuable information to help you make informed decisions about your care, and so that you can go into these appointments ready to advocate for yourself and ask the proper questions you need to ask, and so those kinds of things.
Yeah, I mean, it's something we talk about too frequently here is unfortunately and fortunately, we have to be our own researcher, our own doctor, sometimes we want evidence-based care. We want the best care possible, but that does take sifting through some good and not so good information. So a lot of these tools are wonderful in the aid in that search, but you just don't ever take anything. Your doctor did not have all the accurate information. A Facebook group is certainly not going to have every single accurate piece of information. So it really, unfortunately, does take a lot of discernment, which is, again, where I think we come in on the mental health side. How do we help you discern this in a way that allows you to trust your care team?
Mm-hmm. Absolutely. So I did find a surgeon in Beverly Hills. I did go to her. She does not accept insurance, so everything was out of pocket. So again, I'm in a small population of people that was able to do that. And I have a lot of feelings about that. The consultation went very well. I cried my entire drive home, but it was like tears of relief and gratitude, really, because I felt so validated. Essentially, she saw that all my organs were being pushed to the left side of my body. She also discovered another disease that is really it's a common comorbidity with endo. It's called SIBO, which stands for small intestinal bacterial overgrowth. And I really don't understand a lot about it, so I won't say more than that. But it really explained a lot of the symptoms that I was having with like bowel movements and things like that, which is really common with people who suffer from endometriosis. So
yeah, I had SIBO. Or have you since recovered from that portion of it?
I mean, so I was, so I saw a gastroenterologist out of pocket, also in Beverly Hills, who gave me the prescription, the antibiotics that you need to take, which is Xifaxan and neomycin. Those can be it's difficult often to get coverage for those. If you don't get covered, they can cost you up to $3,000. Mine got covered, thankfully, because this particular doctor is skilled at getting them covered by insurance. But others I think are not. And SIBO, like endo, is a little bit of it's a disease that is controversial and that it's mismanaged and misunderstood. And I've since learned that. So I don't really know if the way I understood it from my gastroenterologist is that I will probably every 6 months or so have to redo the 2-week course of antibiotics, which by the way destroyed me. It made me really sick. And it's hard for me to know if I'm better because I still have the endo in my body. So I don't really know what's what. But we will see after my surgery and I will let you know if I feel better. But yeah, there's like a special diet that, can go with that. What's it called? FODMAP diet. I'm still learning a lot about it. And I think I'm less invested in caring about that one right now because I'm so honed in on these other things that I have going on. But I think SIBO is something I'll become more intimate with in the near future when I have time to care about it more, I guess. But I did do antibiotics in preparation for the surgery because when I have the hysterectomy, essentially, I'm losing my cervix and everything, and they're creating what's called the vaginal cuff. So if there's any straining involved when I'm, going to the bathroom, it can actually open the sutures and create, infection and a lot of problems for me. So that scared me enough to say like, all right, just let me take care of this. And then we'll deal with that later.
Again, yeah, what I'm appreciating the most about how you're explaining your story is this like one thing at a time, which of course, when you're in the midst of it, I'm sure it doesn't quite feel like you're handling it all that well. We never really feel like we do, but the way you're explaining it to me, again, it just sounds very like, okay, put my head down and do this part. And then I'm going to do this part. And then I'm going to do this part. And you're figuring it out as you go. But you're allowing for some of that separation because it can just feel so foggy and so confusing. There's this swirling of stuff in your head and we can get paralyzed with fear. I know I've been in that space where it's like, I don't know what to do. So I'm going to do nothing. So yeah, I don't know if you have any thoughts about that, but.
Yeah, I mean, I think that I definitely feel overwhelmed, especially trying to do my career and take care of 2 young children and, take care of the house and everything. It is overwhelming. But I think that I just kind of had to keep moving because the story essentially continues with this surgeon, she has these sort of prerequisites for surgery, one of which, the SIBO piece, but also pelvic floor therapy. So I definitely needed this post babies, like the level of incontinence, like I would sneeze and I was like, well, time to change, or I would try to work out. And it was really challenging for me. And that felt like it really came from childbirth and labor and just being pregnant. So I kind of went in a little skeptical. I was like, how's this really gonna help me? I mean, is this, really worth it? And, for her, it was a requirement. You had to do 8 of these, pelvic floor therapy sessions in order to have the surgery. So I said, okay. she said, you know, this pelvic floor therapist in Encinitas is just the best in the world. She's incredible. She was actually her pelvic floor therapist, because this particular doctor also has a history of endo and adenomyosis and also had a full hysterectomy. So she sent me to a woman, and I want everybody to write this name down who's anywhere near the area. It's Jandra Mueller. She's a doctor of pelvic floor therapy, or DPT. I'm sorry if I butchered that. She is just, I credit her with everything good that has sort of happened in my life since meeting her. And I'm really, even though I'm not working with that surgeon in LA anymore, which I'll get to that part of the story, I probably would not have found Jandra, because I live about 45 minutes away from there. So it's completely out of my way. But I went to her because it was so high. She came so highly recommended. And then after meeting her, I was like, I would never see anyone else. I mean, she's incredible. She's very smart. She also has endometriosis, which she's very public about, and has had these surgeries, not the hysterectomy, but the excision surgery. So on top of helping me with all the pelvic floor stuff, which, by the way, for anyone who has recently had a baby and is experiencing that, it does work. Pelvic floor therapy, just to kind of circle back, my OBGYN, the one who did the laparoscopy and delivered my babies, had also told me postpartum that I would just need to have a surgery. She's like, the incontinence, yeah, you can't really do anything about it. Pelvic floor therapy doesn't work. You're probably just going to need a surgery. That's not true.
Stop.
Yes.
I've heard of people not recommending pelvic floor therapy, but I've never heard of someone actively saying it doesn't work. And my pelvic floor therapy, if anyone needs recommendations in Atlanta, just send me an email. I've got a few that I recommend to. And I was doing that before my baby was born and after, and I had one moment my entire pregnancy and postpartum where I beat a little. So yeah, other than that, like pelvic floor,
people. Yeah.
It completely reduced my pain with sex in a way that I had no idea was even related to the pain I was having. We kept thinking it was like UTI, but then my test would show up negative, but that's what it felt like. And I'd have micro tears, and it was just brutal. Literally like 3 sessions of pelvic floor therapy. And it was like that and breath work and other stuff, but like pelvic floor therapy all the way.
It works, and it's not invasive, and it's, you know, and I just am learning so much about my body, just things I didn't, you know, I just became so much more comfortable with my body, and understanding what was what in my body that I had never, I've just never experienced that before. So she has been life-changing. I see her weekly. My husband knows, I mean, nothing is going to get in the way of me going to that appointment. If we have a sick child, he stays home so that I can make it to that, because it's that important to me. And it will continue to be a really important part for next steps in my care. So Jandra Mueller, write it down. She's incredible. And essentially, what happened as I was on track to have my surgery with this other doctor in the fall. And then because it's all out of pocket and she doesn't take insurance is really tricky. And my particular insurance has been sort of notoriously known to not cover this procedure. And so if they didn't cover it, which was pretty likely that would be the case because she's out of network, I was going to have to pay $33,000 minimum out of pocket 2 weeks prior to the surgery. So when I learned that, I remember being in my car and I just pulled over to the side of the road and I was just inconsolably crying. And I called my husband and I said, I don't think I can have the surgery. You know, we can't really afford this. And he said, well, we'll just sell our house, which I thought, no, we're definitely not going to sell our house. I mean, we're not going to do that. That's insane. And I called my parents and then they offered to, forego doing their remodel so that they could help me cover it, which also just didn't feel like an option for me. My husband's parents also offered to help, but I don't really have a relationship with them. So that didn't feel comfortable for me either. So I went back to Jandra for an appointment and essentially told her what was happening. And that was the point in time where she recommended to me somebody in San Diego who she had gotten excision surgery from, who she referred to as a unicorn doctor. And I am so grateful that I learned about this doctor. She is incredible. She's in San Diego. She takes insurance. Her name is Dr. Spring Robinson. She is my surgeon now, and she is not listed on Nancy's Nook. And I won't speak to that because I don't understand that completely, but it sounds like there's possibly something political happening there. I don't really know, but she absolutely should be a doctor that people should see. She's the only doctor I will recommend to any of my patients or my friends whenever they're having any sort of symptom related to this, because she is incredible. When I went to her recently, I think this was in early April 5th, I want to say, somewhere in that ballpark. So this is fairly recent. She saw my surgery pictures from 2016. And in other words, she basically said, holy shit. She said, we need to do emergency surgery. And essentially what she told me is that in those photos, which I had been explained that it was, stage 1, really mild, not a big deal, that it was stage 4, deep infiltrating endometriosis, and that my organs are so obliterated that I'm at very high risk of actually needing rectal reconstruction surgery, which explained so many of my symptoms, so much of my pain. And my fallopian tubes at that time were completely covered in endo. And as you recall, my doctor told me they were clear. So there was no chance I was going to get pregnant. I spent 2 years of infertility every month, hoping and, doing anything I could to get pregnant for nothing. I mean, there was no chance it was going to work that way. And my uterus was like, I think she said the words 10 times the size of what it should be. It was a completely different color. Yeah, everything's moved to the left. My organs are like probably wrapped around each other from all the adhesions that I have. And I just, so now my surgery got bumped to May 24th. So it's, next Wednesday, or not this coming Wednesday, but the next Wednesday. And I'm going to be, bedridden for at least 2 weeks. I mean, I'll be able to walk, and I'm being encouraged to walk, but I'm going to need to rest a lot. I won't be able to hold my babies for 6 to 8 weeks, or lift anything over 10 pounds, which basically renders me useless as a mom, because who do you think does all the grocery shopping and, takes the kids to all their activities? And if I can't lift them safely in and out of car seats, then I can't be the one, caring for them in those ways. So it's going to disrupt our lives pretty significantly, at least for the next few months. And hopefully, I won't know really until that day whether my ovaries are staying in. If they are, obliterated, I lose my ovaries, which creates a lot of complications from a hormonal standpoint, which I will have anyways. I will be on hormone replacement therapy regardless of the ovaries, but it'll just be, a much different picture without them. So I'm hoping, it also puts me at higher risk for like heart failure and things like that when you lose your ovaries. So the goal is to keep those in if we can. But TBD on what's going on with potential rectal reconstruction surgery. She won't really know until she goes in there. But it completely explained all of my symptoms for years that I've been having, that I've been told, you're just an anxious person. And it's actually in my file. If you read my notes, it just says, it denies all my pain. It basically said patient denied pain with sex, patient denied, or pain with intercourse, patient denied, this and that. I said, I absolutely didn't deny that. You're denying it on my notes. And it just said, all over my files, patient is presenting as very anxious, which of course I'm anxious. I'm in pain.
I'm so
and I
glad you're saying this, because I have clients with similar paperwork, and to hear somebody else and they don't have an ending yet that validates that pain, and that the anxiety is caused by pain, not the pain is caused by anxiety. So for you to say this, for everyone to hear, I just really, really appreciate.
Yeah, thank you. Yeah, it makes me so angry. It makes me so angry because, again, I think this is so important. And I don't say this to sound, like braggadocious or pompous in any way, but I am very highly educated. I went to one of the top universities in the world. I have one of the highest degrees you can have. 1% of the population has a doctoral degree. It didn't matter. It didn't matter how smart I sounded. It didn't matter how much information or education I had or was able to, provide myself in these areas. I was made to feel so stupid, and so, exaggerative. And I was thinking about this today, doing this podcast, is that I feel like I probably sound, and not just me, but just people that are navigating this system, we sound like conspiracy theorists. I'm like, I need my foil hat, we sound ridiculous because we're like, they're not listening to us. We can't get proper care, and there's no research, and there's only one sentence in medical. And it's like, it's true. But if you're not navigating these systems and you don't know that you have these diseases, then you just assume your doctor's really smart and they know what they're talking about. And I think actually the biggest fear I have for my friends and my patients is when they have a really nice doctor. And this is going to sound crazy, but hear me out. I have some people in my life right now that I suspect are actually have probably something. I don't know what it is. I can't say that. I'm not here to diagnose that. That's me not staying in my lane, right? But I have concerns based on symptoms that are not normal. So I want to say this. If you have pain in anything, that's not normal. If you have pelvic pain, if you cannot have sex without being in pain, if you cannot have a bowel movement without some really ridiculous symptoms, pain, whatever, things going on that shouldn't be happening, and they're more often happening than not, that's not normal. So if you have a really sweet, compassionate, kind doctor that, maybe delivered your babies or listened to you with this one thing, or is really sweet and takes the time with you, I'm worried for you, because I can almost guarantee you that that doctor is all those things, which is great, because doctors should be that, and they should have good bedside manner, and they should make you feel heard and listened to and respected. But if they don't have expertise in this area, they are going to make you worse. They're going to put you on medication that you shouldn't be on. You should not be on these medications. They're going to recommend that you get pregnant, or that you drink alcohol to calm down, or that you take an anti-anxiety medication. And that's great, except that's not going to cure your endometriosis. So you need to fire that doctor, or at least for this particular thing, and find somebody that actually knows what they're doing and has good success rate removing the endometriosis, so that you can live a pain-free, happy, normal life. And so that's what I'm contending with right now, is as I'm talking to friends about this, like, oh, but I love my doctor. He or she, they're so sweet, and I wouldn't want to leave them. And it just, it makes me so, I feel overwhelmed, because I don't want them to go through this.
Yeah, so my take on that, from a therapy perspective is, and you said this too, but keep your doctor, but find, in addition to your yearly checkup with that doctor, find somebody who specializes in this, because having a relationship with a doctor that you trust, that you like, is important. But when you're struggling to find pieces to the puzzle, your doctor is, like you're saying, they're just kind of kindly, compassionately saying, like, oh, like, they're not really giving you a whole lot or referring you to a specialist, then you have to add to your care team. You don't have to get rid of that doctor, but they've just become your general practitioner, and you've got to keep searching for answers.
Exactly. And if they are such a kind, thoughtful, ethical doctor, then maybe you'll help educate them in this area, and then they will be, another voice for you, or they'll be intrigued enough to learn more, or at least refer to the proper person. I mean, every doctor I've seen since then, just for other things, I've said, if you have a woman that's having these things, please send them to Dr. Spring Robinson, because she's here and she's local and she takes insurance and she's incredible, and she, that's who they should be seeing for this. And I just am throwing her name around because I want people to know about her and to be able to find her, because she is accessible to lots of different kinds of people, not just, wealthy, educated, women. And it makes me so sad that that so many of these doctors are not accessible. You know, it's like you find these unicorn surgeons, but then they can only help you if you have money. And I don't think that that's okay.
Yeah,
So.
It's a broken system, which I know we've talked about a lot. And I always wish that we could end that sentence with like, here's the solution to this, fixing this system. And I've yet to find a way to end on that conversation in a way that feels good.
Yeah. I can imagine. Well, I think just you doing podcasts like this does really help, and hopefully it's reaching, you know, a large audience, and, you know, people can share it with their friends or their family members and help them. You know, I'm sure you're helping a lot of people by putting this out there. Not my talks per se, but just all the podcasts, all the episodes that you're doing. It's really incredible.
Yeah,
for you.
I appreciate that. And, you know, this is it's my privilege, because I, you know, again, like I'm in a space where I can take the free time to interview people. You know, I don't get paid for this hour. You don't get paid for this hour. And I'm able to. And so, because I think it's an ongoing journey, but the conversation around privilege and access, and it's like, how do I have a privilege. Can't deny that, and I can't pretend I don't. So how do I use it in the best way that I can? And so far, this is the way that I know how, with my own energy levels and what's important to me and what is meaningful to me. This seems to check all those boxes. And so I'm always really grateful again to people who come on like you and talk about it, so we can just be collaborative in this.
Mm-hmm. One thing I wanted to take a second just to say too, because I think a lot of people in my life right now have been trying to figure out how to support me through this. And I think there are so many sort of platitudes and silver linings that people want to sort of force on me about this, that I don't want. I mean, I never want toxic positivity. I like to complain. I think complaining is like healthy and honest. It can be annoying if you're, you know, if you're not doing anything about it. But I'm a complainer who also does. I act on things and I take care of things. But just let me bemoan and begrudge a system that is, you know, misogynistic, racist, and like you said, broken. Because, you know, I think the squeaky wheel gets the oil, or as they say, right? And so I like to be squeaky. I think that anger is such a healthy, valid emotion. Obviously, it's a secondary emotion, and what lies beneath it is, right, pain and sadness and grief. And I think that is exactly how I should be feeling in this moment. I'm about to go through something really painful, scary, risky. It's going to change my life significantly, in some ways for the better, but possibly in other ways it will create new challenges, and possibly change my quality of life in a sort of negative way. And that wasn't because I wasn't trying to take care of. I mean, I did all the right things and it didn't matter. And so let me be angry about that. And if my anger is not something that can be tolerated, then I think then that those are sort of the people right now that how do I want to say this? I don't know. I think that I've been met with a lot of but you're not going to be in bed for more than 2 weeks, as if 2 weeks isn't a long time to be in bed anyways, or, you know, not being able to hold my kids for nearly 2 months and pick them up. Like, that is, especially for how young they are, that is not just really hard on them, but also on me to not be able to just like be a mom and care for them the way they need to be cared for. They're very young and they need to be picked up and held, and they need to, you know, and I'm not going to be able to do that. And I have anger about that. And sorry, I'm carefully I'm sort of thinking as I'm speaking, so I want to be mindful of that. I think that right now I'm very drawn to being with people that have compatible responses to the situation that I'm going through. And I think other ways that people can be helpful when someone's navigating a big surgery or just these kinds of things, the meal train thing is extremely valuable if you're not someone that is great at validating or empathy, or not sort of jumping to like, let's look at the positive thing and sort of, being Pollyanna. That's okay. Meals are really comforting, or, helping with the kids or helping with grocery shopping, or little tasks like that really can go a long way. And that is really meaningful as well, and very valuable. So
Cleaning your bathroom.
yes,
Like,
please
come over. Nobody will ever ask you to clean their bath. Like when we're postpartum, when we're sick after surgery, I'm never going to ask a family member to come clean my bathroom. So please just offer and just do it.
You know who does do that in my life, so I have to give her credit because she'll probably listen to this. Excuse me, my mother. My mother does clean my bathroom in these moments, and yes,
okay, good.
Very appreciate it because it's true. It's just, it's hard to do when you're not well, and it's necessary, right? You need things to be sanitary and clean for you and for your family. So, I did just want to sort of say that, because I think I'm just kind of looking at my notes because I'd written a few notes that I wanted to sort of say. I just think that toxic positivity gut reaction that people have, because I think they want you to feel better, and I think they also want to feel better. I think it's uncomfortable to sit in that discomfort. And obviously, as a psychologist, I have a much higher capacity and willingness to be able to do that. And I think that it's challenging when a lot of people in your life don't sort of have that, because it can feel extremely lonely, and very dismissive of what you're going through. And it's not the intention ever. I know that, but the impact remains. And the impact is what I'm always really honed in on, more than your intent, because your intentions are probably always going to be pretty good. But if your impact isn't, then it's worth maybe shifting, or at least finding other ways to be supportive for people that, don't require you to dismiss their feelings that are super valid.
It's true. There's such a, where did I just hear this? We're just a grief phobic society. And I cannot remember exactly again where I just heard that to credit them, but we're grief phobic. And so, people, especially if they're not the ones having to deal with it, I don't think it's conscious, and I know their intention is well meaning, but as soon as they start to feel the grief pop up in their own body before they can even consciously be aware of it, they're like, nope, everything's going to be okay. And it's isolating because we don't have that privilege to be able to say, everything's going to be fine. And it's like, no, we have to sit in our body every single day and wonder about what's going to happen. So it's just nice to have somebody else who can be in it with you.
Mm-hmm. Yeah. And I wanted to just in sort of to honor the work that you're doing. I heard this quote recently, and it wasn't about this in particular, but it feels applicable. So I wanted to share it with you, if that's okay. So it was stated by a person named Alok Vaid-Menon. I'm not sure if you know of Alok. They are an internationally acclaimed author, poet, comedian, and just public speaker. And they recently said, there is magic in being seen by people who understand. It gives you permission to keep going. And I feel like you do that by having this podcast and sort of giving a voice to so many people and helping them sort of be understood and be seen. So thank you.
Thank you. Yeah, it's just been, I think, like I said earlier, a beautiful project to connect with each other. Obviously I have my own experiences too, and they're different, and talking to all types of different people, and every single story, whether it's the exact same diagnosis and similar undertones, like there's just something different to be learned in everyone's story. So
And what I appreciate most too, because as therapists, we're really trained to be a blank slate and not share much with our clients. And so just having therapists come on and share their own story is it's just beautiful. I think it makes us better clinicians, and you have more of an ability to connect with your clients. And of course, you still have to, be careful of transference, countertransference, and all that stuff, but you have to do that anyway, right? So, yeah.
Absolutely.
Thank you.
No, thank you.
Is there anything else that you wrote down or that you've been thinking about that feels important to expand on?
Yeah, I'm looking. Well, I don't know if you might cut this out because it might be ridiculous, but I was sort of revisiting, I don't know if you've ever read, I'm sure when you were in, junior high or high school or something, like Plato's Allegory of the Cave. It's like a philosophy.
I didn't read that one, no.
Okay. I am not a philosopher, so I will not explain it, but for people that want to read it. But essentially there's like prisoners that are in a cave, and then they spend their whole lives in there, so that's sort of all they know. And I think they're like looking at their own shadows on the wall of the cave, and that's significant for some reason. But there's a few that manage to, I think, escape. And the whole notion is that the people that come back to be like, hey, there's like this whole other world out here. Did you know? Come out here and look. They the idea is that sort of like the other prisoners that stayed in the cave would either like try to kill those people who are trying to kind of free them, because they wouldn't want to leave kind of the safety and comfort of their known world. And that made me think of people that are navigating medical conditions and navigating the health system, is like they have information and experiences now that have shown them a different world than what so many people know and understand. And when they try to explain that to people they're not ready to hear it, because it's just feels scary to think about, oh, my doctors that I'm trusting maybe don't know as much as they think that they do, or maybe they don't care as much as they should, or, a variety of things that people might feel when you're sort of planting seeds of doubt in this world that feels safe to some people. So I don't know why, but I felt inclined to kind of share that because it stayed with me. And I thought, yeah, that's kind of how I feel right now. Like, I want to free everyone. I want everybody to know and to get the proper care for endometriosis. And I'm worried that they're not. And I like want them to change who they're going to see and all these things. And I realize in doing that I'm sort of, that is a little bit, what's the word I want to use? Words are not coming to me. By the way, fogginess is a symptom of endometriosis, brain fog, which I've also since learned, which makes a lot of sense. But I think it just shakes their foundation, and that is scary. People don't want to think about the world that way, right? They want it to feel safe and trustworthy. And so when someone comes in and says it's not, listen to me, that's where that conspiracy theorist thing kind of comes up, is like this, the crazy lady on the street again yelling about endometriosis. I feel like that's who I'm becoming. I'm gonna have like signs on my garage, you need excision surgery. So
isn't it? It is, when you are one of few that have experienced something. Again, it's isolating, and it makes you question your own experience to a certain extent. And again, that's another reason why I do this podcast, because the whole goal is to demystify the therapy process for people with chronic illness. Like, our goal as a therapist, especially because people have been, oh, this is all in your head, go see a therapist. And it's like, actually, this is actually very much in your body. And now, as a therapist who has lived experience and a lot of additional training around chronic illness and the mind-body connection, I can help you navigate this system in a much different way and create safety pillars along the way. I mean, that's a big piece of somatic experiencing and just trauma therapy in general, is that we're always creating safety before we say, hey, go out of the cave. It's like, it's interesting, as you were saying, like the Plato's and the cave and the shadows. I was like, the shadows are a resource. You probably would take your shadow along with you in order to do a journey like that, so that you can feel the familiarity and the safety of the cave, which was all you've known. You need your shadow, so take it with you. as you kind of go out into the world and try to expand your worldview.
Well, and as you were saying this, it's a really important point came up, because I want to hold my field accountable as well, because I've really been coming at, medical doctors today. And thanks for still listening, guys. But I also want to come for the field of psychology, because I mean, holy cow, where did most of these problematic ideas about women and hysteria come from? They came from Freud and others and his, colleagues, and they have, it's insane how long that they have managed to, hang around in this really dangerous, misogynistic, disgusting way. But psychologists, I mean, when I was navigating this pain, I mean, I did go to couples therapy to work through some of the, sexual dysfunction that was happening. And not once did anyone think to say, hey, have you had your hormones tested? Like, let's start there before we dive into whatever might be going on from a emotional standpoint or psychological standpoint. Because it turns out I have no testosterone, zero. And a lot of that's because of the endo, because it's so high in estrogen. And it's also normal for women with endo to not want to have sex and to have low libido, one, because of the estrogen, but also obviously because of the pain. But I mean, the hormone thing, it is such an easy, it's like a prick of, blood. And then you sort of find that out, and nobody thought to do that all these years that I was like, hey, I think something's wrong. It's like, just drink some wine. I'm like, great. Thanks for trying to make me an alcoholic. I don't think that's going to help my situation. Also, alcohol is a depressant. It also creates a lot of other problems, I'm sure. I would imagine dehydration, which probably doesn't help with lubrication, which is an important part of like healthy sexual functioning. But I digress. I just felt like I wanted to say I was also failed by my own field. And I imagine I have or will also fail people in these areas. As a doctor of psychology, I know that I have probably created harm unknowingly. And so I just want to say that it doesn't start and sort of end with the medical field, like the field of psychology and we as therapists and all these different disciplines, whether it's acupuncturists, et cetera, because a lot of them that I went to also didn't know anything about endo. And of course not, they can't know about everything. But I think if you don't know about something, it's just important to say that. I don't know about this, let me get you to someone who knows a lot about it.
Well, as a society, we do believe like physical stuff is a manifestation of your mental, emotional state. And in other cultures, it's the exact opposite. If you have depression or anxiety, it's like, oh, what's wrong with your body? And they target it from that way. And I think that could also miss the mark on a lot of ways too. So I just love that we are kind of going into this kind of like functional medicine is a lot more kind of East and West combined. And that's where I have found there's a lot of pitfalls in that field as well, every field, right? But I do definitely just being able to, and this is where your education becomes, it is a privilege in a sense too, to be able to take all this information and then differentiate for yourself, figure out what's right and what's wrong. Like that takes time, that takes energy, it takes education. So again, this podcast, your story, like it's just, you have to constantly be picking up pieces. And, the alcohol thing, I really wanted to say this earlier too, when you were mentioning it. And it's like, women are so taught to not feel pleasure from religious standpoints, from patriarchal standpoints, from every system. It is terrified of female pleasure. So it finds ways to reduce that. And, I have a lot of women that I work with, and this was my own experience too, trying to kind of figure out how to have sex without alcohol. Like, and we could do a whole other podcast on that, but in your younger 20s, if you drank, I do know some people that didn't, but a lot of us do. And it was like, oh yeah, well, how do you feel pleasure? How do you get turned on? Well, I don't know. Cause like I would have 4 drinks before I'd have sex.
Right.
Right.
Well, and see, it's funny you're saying that, because I actually didn't drink in my 20s. I didn't drink ever until I was 25. So that was the other piece of things, is that I was being recommended alcohol. And I was like, but I don't drink. I mean, I hadn't had like a sip of alcohol until I turned 25. And so there was that too. I'm like, can I get maybe a recommendation that feels a little more appropriate for what I'm able to take on here. But yes, but to your point, I mean, that was just, sorry, a digression there, but yes.
No, it's important. Yeah.
Right.
Either
And
what that tells me is either way, it was bad advice, because if I'm a drinker, don't tell me to continue drinking to get rid of my pain like that. I'm already at a risk for alcoholism. And if I'm not a drinker, then it's just totally out of alignment with me and my lifestyle.
Exactly. Yes. Yeah. It's just, but to your point, yes, women's pleasure. There was an interview that Madonna did about this. A long time ago, probably in the 90s. And I don't remember who the guy was that interviewed her, but I mean, classic, right? Just male that was sort of talking about how disgusting her videos were. I think she did a music video where she's, masturbating, or she's insinuating that she's going to, or that she is. I don't remember exactly even what video it is. I mean, it's Madonna, so it's probably every video, but she said something, she just responded in this way. She was almost smiling, which kudos to her, because I cannot, but she just said, why are you so afraid of my pleasure? Something, I don't want to butcher her words. It's worth sort of Googling that interview, but it just really stayed with me. And to your point, I mean, a 90-plus-year-old man could go in and say, hey, I'm having trouble having sex. And listen, I'm not here to say a 90-plus-year-old man shouldn't enjoy sex. Like, you enjoy it all the way. You deserve that. But I was, in my early 20s, and I was being told, like, you'll be fine. You're just nervous. And there's not, a Viagra for women. It's testosterone, which, by the way, isn't FDA approved for women. So it's not covered by insurance. And it's the only thing I can take right now to supplement, to have actual testosterone in my system, which is a necessary hormone to have to experience pleasure and to, I'm sure, a number of other things. And so I have to pay out of pocket. So again, this is only accessible to certain people, certain populations of people. And
as if testosterone is something that only males have.
Precisely. Like women, just like men have estrogen, women have testosterone. And also, let's just talk about the fact that we're speaking about things on like a very binary, male versus women. There's all kinds of things in between, right? Like intersex people and non-binary. And, so everything I'm saying today, I think I use the word women a lot. And I hope that it's just known that when I'm saying that word, I'm including, everybody sort of under that umbrella, because I want to make sure I'm being inclusive too. And when I say I work with, women with chronic medical conditions, that includes everyone.
So that interview you just heard was from a few months ago, and the follow-up to Dr. Anna's story is coming right now. It's another 15 minutes or so, and it was recorded just this week. So I hope you enjoy.
Yeah, so I talk about this at length, over 2 hours probably on another podcast called I Care Better, which is a really good resource for anyone that listens to your podcast who wants to know more about endometriosis and, related illnesses that often accompany endometriosis. So I recommend that to all the listeners. And I hadn't mentioned that in our last, the beginning part of this episode. So that's a great resource to know. And yes, I was really surprised by how well I felt immediately after surgery. Areas of my body that have been in pain probably for the majority of the last, 20 or so years, they were immediately gone, which is pretty incredible when you think about the fact that I had, excision surgery, for deep infiltrating endo, stage 4 endo, and a hysterectomy. You'd sort of imagine that you'd be bedridden or in quite a bit of pain. And I certainly was the minute I woke up from surgery. And they gave me Dilaudid. And then after that, I never felt that pain again. I definitely stayed on top of my Tylenol and Advil, which is all I ended up needing to take, which was also surprising to me. And after 2 days, I was off of everything, which I was not expecting. And I was walking, and I actually felt so well that it was a little bit dangerous, because it sort of gave me this impression that I could do more than what I was allowed to actually do, right? Post-surgery, you can't lift anything more than 10 pounds. So my children, groceries, lots of things. And, you need to take it easy. You obviously can't have sex. You can't go in any body of water other than a shower, for risk of infection and things like that. So other than those things, which were, minor inconveniences, I did so well. I think the since then, it's been, what I'm sort of realizing is that this is going to be a process. I think it felt so amazing to feel so good right away and pain-free. But it's not just pain, right? Like there's so many things that accompany, these diseases. And in my particular case, the lack of testosterone. And I was able to keep my ovaries, because I think I keep forgetting we recorded this right before my surgery. So I know there was the fear of, am I losing organs? What's going to happen? So I had a partial hysterectomy, was able to keep my ovaries. That's the only thing, I kept. The cervix, the fallopian tubes, and obviously the uterus, all of that was removed. My uterus was so enormous that she had to cut it in half to actually get it out of my body. Yeah. And then as far as the other concerns we had, I got very lucky that nothing else needed to be sort of removed. She was able to remove all of the disease. I really trust her. She's an incredible surgeon. Again, that's Dr. Spring Robinson. She's in San Diego for anyone who's close to Southern California or can afford to travel. I couldn't recommend her more. In terms of like the process that I was sort of telling you about, a lot of that is the hormonal piece. And I was put on systemic testosterone following the surgery by a different doctor who handles all of my hormone related things. And like, she's also a sex medicine doctor. So she's the one that's really helping me through that piece of the puzzle. Her name is Dr. Alyssa Yee, also really highly recommend. And we were on systemic testosterone, and my body, the way it metabolizes things, it's just, every body is so different. And I think this was a really helpful reminder to me about that, right? That particularly things that are not FDA approved for women, which is systemic testosterone, they don't have like any studies on the amount and things like that. So what ended up happening is that I used the recommended amount, but it ended up increasing my levels 10 times over what they had been initially, and then 3 times over the limit of what they should be, which equals that I felt completely out of control rage and depression and anxiety, and I was really impossible to be around. I didn't even want to be around myself. It's like that horrible feeling of I want to get out of my body and take a vacation and like leave that satanic woman, in there by herself. It was really awful. And then once I figured out that that's what it was, I was taken off of that. We took about a 3-week, 4-week break, retesting, and then we'll kind of start again with much smaller doses. The other thing she put me on, and I definitely wanted to alert people to this because it's very cool. I hadn't known about it. There is a drug for women who have, no or very low libido and are wanting, right, to increase that. And it's called Addy. It's spelled ADDYI. I just started it about 2 weeks ago, so it's too early to tell. I can't really give you an update in terms of how it's making me feel, but I will tell you that the testosterone really helped. While I was on those insane levels, I definitely felt, like feelings and desires that I hadn't felt in so long. So that gave me a lot of hope. Between those two things, I think that I'm headed in the right direction. I think one thing for people that are going through a hysterectomy and someone who's possibly had, sex related issues as well, it can feel, I think, very scary to dive back into that and try that after you've, had all this done to your body. And, you don't have a cervix anymore. It's replaced by what's called a vaginal cuff. And I think for me, there's still a bit of like a fear there of what's this going to feel like? And am I going to feel pain? And so there's a bit of avoidance still that's happening. And I wanted to really give my body more time just to heal and not rush into that. So again, I don't have updates in that department of my life, but I feel hopeful, and I hadn't felt hopeful in the longest time. So I think that's pretty exciting.
Yeah, that's really exciting. And I think hopefulness is often to just a sign that, yeah, things are going right. Like we can be, that hopefulness helps us get there too, right? So it's like, it's bi-directional. We need some positive things to happen to bring hope, and then hope kind of makes the good things happen more. And it can be, what's the word I'm looking for? Kind of like just work off of each other.
Mm-hmm. Yes. Yeah. And I think, the other piece is just that this is really a lifelong, this isn't a cure. I mean, in the majority of cases, most women do not need another surgery, but a lot of that is also up to them, right? And how they manage their, life afterwards. And it's really a lifestyle change. And that part has been a challenge for me as far as avoiding inflammatory foods, or foods that cause inflammation, and living sort of an anti-inflammatory lifestyle, because that's so many of the things that I love, right? Sugar, coffee, a glass of wine, just carbs, pasta, I don't know, all the things that not, that probably impact my body and can create endo to begin with. So I'm just sort of recognizing, I think I knew this cognitively, but now I'm really living it, and I'm recognizing that this is going to be a process with probably some highs and lows, and moments that I get frustrated with myself, and then moments where I'm really sticking to my goals, and I think I'm just trying to accept that and not be perfect, and just allow myself to kind of navigate this life, right, post surgery. Pelvic floor therapy is an ongoing thing. It will probably be a big part of my life for the majority of my life, which I'm happy about, because I absolutely love my pelvic floor therapist. She's fantastic. And I had mentioned her as well. She's Jandra Mueller. And she's actually the host of this podcast that I mentioned. For, again, anybody local, she's wonderful. So those are kind of the things that I'm wrestling with, figuring out still. But as far as pain, that feels, it's an incredible feeling to live a fairly pain-free life, at least for now. And again, that can shift, I imagine, as depending on my habits. And yeah, I think that's also really helped, depression and anxiety. I just feel so much better. And I can't recommend, going to a good excision surgeon. I think that's so important. It's very hard to find one. A resource for that is the I Care Better website. Nancy's Nook as well is helpful, but I think as far as the video vetting that I Care Better performs, I feel more secure utilizing that particular organization. So yeah, those are kind of I don't know. I wonder if you have other questions for me. I'm sort of going on. So
yeah, the only other question, no, that was great. I think it's just good to hear, even, things that people don't think about, the hormones you have to go on after, and like the fact that women are not tested, or it's not FDA approved. And so we don't quite know exactly what the right dose is, and that there is still a bit of a trial and error in a lot of these processes. I think that's a big theme of this podcast, is that just about everything, honestly, in life and in chronic illness is a lot of trial and error. Mm-hmm. And in that process, there's a lot of injustice. And then there's also just a lot of there wasn't an injustice done, but this still just didn't work out well. And we have to figure out how to navigate that. And so that's kind of what I'm always gathering from these experiences that people share with me. And I think, I'm curious if there are any other lifestyle things. So eating kind of anti-inflammatory, mm-hmm. Pelvic floor therapy. What are some of the other things for you anyway that were recommended lifestyle?
Yeah, great question. So exercise, and, some sort of like mindfulness or meditation or yoga or things that, whatever your way of relaxing and feeling somewhat grounded. And that looks different for so many people. And some people really don't like meditation. I'm one of those people. I'm just really bad at it. But just anything that you can do to really sort of, find some peace, calm yourself. I think massages, regular massages will be important. Things like acupuncture can really help. It's so case by case because, the way endo presents in each body is so different. And there are so many people with endo that have the amount of comorbidities that some of these women navigate. It amazes me. And I see that a lot in my work, in particular, but it's pretty incredible to me. So in those cases, those types of patients have a lot more on their plate, I think, than I do at this point. But those are some of the most kind of recommended things, and just really good, multidisciplinary care, right? If you have a surgeon that you love or a doctor that's working with you on one thing, you need to make sure that they can communicate and, that no one's stepping on the other's toes. I think a gastroenterologist will be important. That's something that I've had to add to my life. And that's mainly because of the SIBO that I was diagnosed with, which I'm still figuring out. And it's not a high priority for me at the moment, I think, because I just have so much to take care of that I'm kind of like, okay, I know I have SIBO and I have to deal with that. And that has a lot of inconsistencies in the, in the medical community. So it's a little difficult to navigate, I think, because you read one thing and then you read something that completely contradicts that from two seemingly reputable sources, which is probably so common for your listeners, right? That is what is so frustrating and, rage inducing, because how do you know which direction to take and if you're making the right choice? And so those are kind of the ongoing struggles. And I anticipate those to be ongoing for a long time. So I'm just kind of in a place of trying to accept that and figure out how to, live a fairly balanced, well-rounded life. And I don't have the answers yet, but I'm taking it one day at a time. And I think that has felt more manageable for me.
Yeah, no, all of that is, right up the alley of this podcast. We do talk a lot about all of that. So I just really appreciate you sharing your story. It just goes like completely aligned with everything we talk about. It's hard making these decisions, these lifestyle decisions, especially when there's like differing opinions on what you should and shouldn't do. And it's complicated, but
it is.
We did talk a lot in our last episode too, just about support. And that's, again, what we talk about on this podcast. Like, how do we find the support that's right for us? Because that is such an individualized process. So anyway, thank you so much for sharing an update. I'm excited to air this episode. Anything else come to mind for you?
Just oddly enough, I forgot to mention therapy. And I'm a psychologist, so I should probably say that therapy also can be very helpful and an important piece of the puzzle, right? Just to work with somebody who has an area of expertise in chronic medical conditions or health psychology, so that you can also get support from them as you're navigating difficult doctors or difficult decisions. Sorry, that was no, absolutely. The way I've made it forget that one.
Yeah. And just, for listeners, like, you can always email me and ask if I know anyone in your state. I've had people email me, and I will one day get a directory together, but that's on the back burner for now.
Yeah, no, I know it's a lot. You have a lot on your plate. But for endo related patients listening, the best directory at the moment, I'd say, is I Care Better. So that is a great resource for them, and they can look for people in their state. And there's a lot of work that's expanding in that particular area. So I hope endo patients feel a little more hopeful that they'll have better access to care soon. I'm seeing that trend.
If they have a therapist directory, is that what you're saying? Like for talk therapy?
So I'm actually the person working on that at the moment. Okay. Yeah, okay. I was the director of this organization, or the founder, I should say. Heard me on the podcast and reached out to me. So I'm currently working to we're starting with California, just because that's where I am and I know all the laws there. And then the goal is to expand that, throughout the country and be able to help people find access to therapists specifically, but the surgeons are on there and pelvic floor therapists. And
Perfect.
it's an ongoing effort to keep recruiting more people. So if anyone listening is a provider that specializes in this, whether they specialize in endo, you can fill out an application, you can, reach out and I encourage anyone to do that. Absolutely.
That's great. Amazing. Well, definitely let me know when that directory, keep me updated and I'll share that email list as well.
I definitely will. Absolutely.
All right. Well, thank you. I'm looking forward to putting this out, and yeah, we'll keep in touch.
Thank you, Destiny. Thanks for taking the time to interview me again. I appreciate you.
Absolutely.
If you learned something new today, consider writing it down in your phone notes or journal and make that new neural pathway light up. Better yet, I'd love to hear from you. Send me a DM on Instagram, email me, or leave a voice memo for us to play on the next show. The way you summarize your takeaways can be the perfect little soundbite that someone else might need in order to better absorb the same lesson. Lastly, leaving a review really helps others find this podcast, so please do so if you found this episode helpful.